यार ये फिर आ गया। हो जाता है। हो गया? कैसे किया? अच्छा। ओह अच्छा। पहले तो तुम कर रहे थे, नहीं हो रहा, इसको दे दो ना। कौन है? अच्छा, आप इसको दे दो, चांदी को दे दो।
So we are good to start. We are live. Can we begin?
Yes.
Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. He needs no introduction, but it's my pleasure and honor to introduce him at our platform. And he's none other than Padma Shri Dr. Mohsen Wali sir. Sir is MD, FACC, FRCP, FICP, MRCP, FIMSA, FGSI, FIAMS, FIACM, and Senior Consultant at General Medicine at Sir Gangaram Hospital at New Delhi. With the help of sir, we'll be taking a close look on today's topic, which is management of atrial fibrillation. Before moving on to today's topic, let's have a brief look on what the topic says. Atrial fibrillation poses a significant burden to patients, physicians, and healthcare system globally. The complexity of AF requires a multifaceted, holistic, and multidisciplinary approach to the management of AF patients with their active involvement and partnership with clinicians. We'll be knowing more about the topic with the help of Sir. Now, without any further delay, I would like to welcome Sir at our platform and would like to hand over the session to him for his talk to begin. Sir, over to you.
Thank you, Batul. I will wish happy Navratri to all the audience and happy Ramzan also to all the audience for the country betterment. And as you rightly said, this is causing a significant burden. And that is how we are very concerned about it. So the burden of atrial fibrillation is just like when we have a healthy heart and disease heart. That makes a big difference. And this healthy heart is so cool, and the sinoatrial node at the top, atrioventricular node at the bottom of the atrium, and that Purkinje fibers right and left, going right bundle of his left, bundle of his division. So this is now fibrillating. This is mad heart. Now it is fibrillating and causing discomfort, is causing arrhythmia, and is getting erratic. And these four points you are seeing in the atrium is a point of interest. Behind that are the fibers. So those fibers which we are going to ablate later. So this is how the atrial chaotic rhythm, and this is what we call typically is irregular heart. Irregular in the volume and irregular in the beat. That is how it would. We will see in the further different cartoon. This is a normal beating heart, circulating blood. And this slide also, video also shows the ECG going very regular at the background. Impulses arising from sinoatrial node and regularly pacing the heart. The heart is being paced. It's a cardiac pacemaker. And left atrium, right atrium, right ventricle, and left ventricle, they work in synchronization. So there is no fibrillation. So there is synchronization, and the blood is going very smoothly. Things are now this has started irregularity in the beating, in the force, both. You can appreciate the irregularity, everyone can appreciate. And what happens as a result of irregularity? There is a circulatory dynamics which changes. There is activation of the clotting mechanism. There is a fibrillating atrium which does not produce a successful contraction, pushing the blood down to the ventricle. Then there is a right ventricle, left ventricle fibrillating. No P waves are seen in the ECG. And you see the complexes at the different intervals. So they are irregularly placed in the height, and there's a pooling of blood in the atria. So as a result of pooling of the blood, there is a clot formation, and this clot is very dangerous. This comes down and goes up, going up carotid tree. Now it's going up to dislodge. Most common place we know by the knowledge of theory is middle cerebral artery. This is going up and the clot is being seen. It can go onwards also to middle cerebral artery, is the most common place to get this clot lodged. And the result is neurological deficit in the form of, there could be hemiplegia, stroke, sudden loss of consciousness, vomiting, edema of the brain, and so on. So, atrial fibrillation is the most common cardiac arrhythmia. Irregular, narrow, complex tachycardia due to irregular atrial activation, and the rate can be varying 350 to 600. Spontaneous discharge by the ectopic pacemaker cells in the large pulmonary veins at the point where they join. So these are simple slides. I will just go through them. This shows the normal sinus rhythm as we saw. And this right side of this shows chaotic atrial fibrillating impulses. So this classification of atrial fibrillation, it could be less dense, more dense, and very dense. If we graphically interpolate it, could be paroxysmal, persistent, and permanent atrial fibrillation. Now, the ECG features is P wave is the hallmark of the diagnosis, which is absent, and there can be fibrillatory waves. The QRS complexes height may vary. They are irregularly placed. That is why we call irregular pulse, means irregular in the rate and volume. As the age increases, incidence increases. More common in white than blacks. In Indians, it is quite common, more common in men. And pathophysiology, as I explained recently, there are mechanisms due to hemodynamic stress. There's the atrial structural abnormalities, most common in India after the rheumatic heart disease, mitral stenosis, hypertensive heart disease, ischemic heart disease, and idiopathic lone atrial fibrillation. There could be electrophysiological mechanism and other pathophysiological mechanisms. So we have a mnemonics like pyrates, pulmonary embolism, pulmonary disease, post-operative pericarditis. This is PEs, ischemic heart disease, idiopathic, I told idiopathic lone atrial fibrillation, intravenous central line, after central line stimulation, rheumatic valvular disease, then anemia, alcohol, advanced age, autonomic tone, vagally mediated, thyroid disease, very important cause. I forgot to mention in the list, elevated blood pressure, hypertensive heart disease, electrocution, sleep apnea, sepsis. As I've told you, it could be paroxysmal, persistent, long-standing, permanent. The clinical features, normally there can be none. Patients can be walking with AF. When we see the ECG, we see irregular pulse clinically. First ultrasound may be loud or variable intensity. Physical examination may show the sequelae, the previous presence of atrial fibrillation sequelae. And patient can even be serious from asymptomatic to cardiogenic shock or CVA. Many patients present as CVA. So we have to be very careful. Just if you remember these 6 rectangles, palpitations, unexplained fatigue, dyspnea, dizziness, anginal pains in copy, this might give you a clue. So this is the usual workup we do as a cardiac patient. Then most important is transthoracic echocardiography, and in the previous workup, most important is ECG, BNP, chest X-ray. So we have to do transesophageal electrocardiography also, evaluate for atrial thrombus, which is not normally picked up in a routine echocardiography. Then we have to decide the further course of action. We can see the thrombus like this, left atrial appendage with thrombus. We can also do Holter monitoring, which is very important evaluation. Then The complications, as I mentioned in the cartoon, were CVA, TIA, systemic thromboembolism, pulmonary embolism, splenic infarction, so tachycardia-induced cardiomyopathy, cardiogenic shock. So that completes the basic description of atrial fibrillation. Now, about stroke in atrial fibrillation. There is a clot formation, as I have told you, in the left atrial appendage, goes to the circulation, left side goes to the carotid, goes up in the middle cerebral artery, and with atrial fibrillation, stroke risk 3%, more than 60 years of age, 30% more than 80 years of age. Without atrial fibrillation, which is very low, 0.5 and 3. 3% actually. This is 80 years, 3%, not years, it's 3%. So this is misprint. I'll have to correct this. So we have to see. So the basis is blood stasis, anatomical and structural defects, abnormal blood constituents, most importantly, clot. Now, how to manage atrial fibrillation? So basically, we have to do rhythm control and or rate control and thromboembolic risk prevention, because this leads to great disability. So special considerations are whether it is post-operative. We have been recommended beta blocker, perioperatively hyperthyroidism, beta blocker, dual dihydropyroxylate, CCBs, calcium channel blockers, dihydropyrimidine, calcium channel blockers are used in different situations. In this non-dihydropyridine calcium channel blocker, the drug of choice in the COPD, also heart failure. This is the basic outline. And procainamide-like drugs we use nowadays, cardrone, amidrone, very commonly in WPW and pre-excitation syndromes. Dioxin was used in our times much. Now we have better drugs. I will show in another slide. So how can we help? This is a big question mark. How can we help? It's a big rate. We have to slow down the rate by the pills, by the medication. And new onset atrial fibrillation for hemodynamically stable and unstable patient, the management is different. So I have told you briefly about rate versus rhythm control. More than 65 years of age, less symptomatic, with hypertension, recurrent atrial fibrillation, rate control is a must. Rhythm control indications are first episode, reversible pause, symptomatic despite rate control. So these are the basics of. Then in cases where it is not responding to these routine pharmacotherapeutic measures, cardioversion will be achieved by pharmaceuticals like cardioversion or electric shock. So it could be medical cardioversion or it could be electric cardioversion. So this is the detailed slide. I will not go into the details. Then second, how we can help is to prevent a stroke in anticoagulation. So anticoagulation, we have newer anticoagulants like dabigatran, rivaroxaban, bixaban, endoxiban, novel oral anticoagulant agents. Then we can ligate the left atrial appendage. It's a very small surgery. Effective anticoagulation in patients with atrial fibrillation reduces the risk of stroke threefold after 4 to 6 weeks. So long term. Then there are these are the scores: H for hypertension, A for abnormal renal liver function, S for stroke. We give on markings, and this score is important: 0, 1, 2, 3, 4, 5, and these are the chances of bleeding, roughly, I would say roughly. Similarly, we have CHADS2 score, thromboembolic score. Management of toxicity of the various agents is to be very, very carefully studied before we start them. Even these novel oral anticoagulant agents are having good toxicity. There were, when initially they came, there were a lot of articles in American Heart Journal about their bleeding. So we have to be very careful, and we should be ready with antidotes all the time. So long-term management is we focus to reduce the recurrence, to reduce the symptoms, to control the ventricular rate, and to reduce the stroke. I will skip these slides. I have told now complications. Most important is the heart failure, and then we have to put a pacemaker also in some selected cases. Pacemakers for a slow heartbeat have one or two insulated wires then run from the pulse generator inside the heart. So this extreme bradycardia or sometimes electric this thing cardioversion fails, then we have to take help of the pacemaker. Now this is the most commonly used drug, amiodarone. We give a bolus, then titrate. Then ablation is the technology which helps us in the modern times. And we have a mapping catheter put in the left atrium. Then we have spots. I will be in detail explain these spots live in my next two videos. And then you have to ablate them under a very special supervision. This catheter goes to LA by inferior vena cava through transseptal approach. The classic medicine which was used, warfarin, is still used, and most of the cases in which there is post-RHD, we use this. Then they are a word about dabigatran, that is Redexa. Then I have just given them just to revise. Otherwise, each medicine we can speak for 1 hour. Endoxifen is not much used in India. So updated guidelines of American College of Cardiology, American Heart Association for patients with atrial fibrillation and elevated JEDS2 score, vascular score of 2 or greater in men and 3 in women, oral anticoagulants are recommended. This is the most important statement, and further details are adding other risk factors and warfarin and aspirin use. So now, how can we help further? This is the slogan I am carrying on. Restore a normal heartbeat with electric cardioversion. If we understand the pathophysiology, this is the pathophysiology. Various causes, coronary artery disease, amyloidosis, sarcoidosis, all these conditions causing fibrosis, disturbing the stretch and abnormal conduction. So what we have, how we can help is to restore the pathway of the impulse traveling and to cancel the abnormal conduction. Now, what is the new in atrial fibrillation in day-to-day practice? There is a lot of scope of, we can talk about variables in atrial fibrillation. So variables can be from smart glasses, smart watch, most commonly Bluetooth key tracker, smart shoes. So basically, aim is to find out if there is a fall in oxygen saturation, physical activity tracking we can do, heart rate monitoring is most important, arrhythmia detection is further important, blood pressure, blood glucose, and even obstructive sleep apnea can be measured. Then fall detection, how prone you are. This is through the balancing gadgets. So event monitor and external loop recorders are there, patch monitors are there, mobile cardiac telemetry is there. So these are the things which we can do. So we can say advances in monitoring devices have substantial changes we have made over the past decade, and detection of atrial fibrillation and implantable cardiac generators or monitors. They are very good for arrhythmia detection and treatment and management also. And there are increasing opportunities for arrhythmia detection and monitoring using wearable devices. Some of them I've shown, and we are daily advancing on them. Interpretation of arrhythmias at a cardiologist sitting at a distance can be done by telemetry. And most importantly is that we have to advance these devices and their contribution to the diagnosis and detection. So this is one of the methods I would definitely like to discuss. Uh, this is left atrial ligation, and then this is a device called Watchman's left atrial appendage occluder, which consists of a cell expanding nitinol frame covered with permeable polyester fabric. So how this works? See how much Watchman device works. It's a very interesting video I have got somehow. Though there are other methods to treat atrial fibrillation, and MACE is one of them, but this is most effective. Like this blood clot usually rests in the left atrial appendage. So under general anesthesia in a cardiac catheterization lab using fluoroscopy, uh, a catheter is guide wire is passed, and this Watchman device is inserted like this. You go through the vein up right atrium, transeptal left atrium, left atrial appendage thereafter. Through the guide wire, we push this device. This is the ablation device. Pigtail go to the left atrium. And this is the actual device. It clogs the left atrial appendage. This is the endothelial device, and this is fitted, and there's no need to cut. In the other procedures, we cut the left atrial appendage. So this is, we have embolized to prevent the embolization. This is how we can say. So summing up, I can say that there are many advantages and advances in the management of atrial fibrillation. And I have this last video to show that we can do this. All the fibers can be ablated, and this can be dual method of convergent procedure, in which we go inside the heart and outside the heart, and we burn the fibers. And this is outside the heart. We do electrocoagulation of the area between the two pulmonary trunks. And what we do, basically, we try to create a confusion to the pathway of the electrical impulse, like macing. Here is another operation exactly for macing. So this is another short video explaining. From the inside of the heart, the same area is electrocoagulated. So we have to do a combined procedure. This is done by a surgical team plus a medical team. And that's how the atrial fibrillation is managed. So summing up, we can say we have, apart from that, some lifestyle modifications also to prevent, like these are the agencies which like our NGO, they have said, eat right, use medications whenever required, stop smoking, and be active, reduce stress. So the emphasis is on exercise, breathing exercises, meditation, yoga, adequate sleep, spend time with loved ones. So that's how we manage the atrial fibrillation, and one of the very common arrhythmia. And I would say thank you very much for listening to my talk. I have tried to cover most of the things, but some more finer things I have skipped. So basically, the resistant atrial fibrillation is dealt with electrocardioversion and also by ablation techniques, which could be from outside and inside or combination of both. Thank you very much.
Thank you so much, sir, for the comprehensive talk and such wonderful insight that you have shared upon the topic. I hope that all the viewers who have joined us must have gained the knowledge that they were here for, and they are going to definitely gain the information and would definitely help them in their daily clinical practices. So thank you so much, sir. We have received a few questions, sir. With all your due permission, I would like to put it across to you. The first question is...
Already we are late. Anyway.
Yeah. The first question is, what is the role of Holter monitoring and event recording for atrial fibrillation?
You see, sometimes CCG misses atrial fibrillation unless we very keenly see that Holter monitoring now we are doing for 1 day, 2 days, 3 days. Most importantly, in 1 day Holter, we pick up the atrial fibrillation. This is important since we have facility, we have portable Holters also, small Holters also. The importance of recording Holter is that when it is precipitated, suppose after food or after alcohol, during sleep, so we can pick up the length of the segment of atrial fibrillation, variability of the atrial fibrillation, and frequency of atrial fibrillation, relation to sleep for atrial fibrillation, and many other things.
Thank you so much, sir, for answering this question. We'll move to the next question, and the question is, what factors increase the risk of bleeding with anticoagulation in patients with atrial fibrillation?
Most commonly liver disease and some inherent coagulopathies. Otherwise, we monitor, we keep the INR to between 2.5, 1.2 to 2.5. This is the ideal INR, and it keeps varying. You see, you can't keep it geometrically 2.5. So we adjust the dose, call for a follow. The conditions in which bleeding prone is usually vitamin K deficiency, fibrinogen deficiency, and chronic liver disease, chronic alcoholism, and some inherent coagulopathies.
Thank you so much, sir, for answering this question. We'll move to the last question for today's session. And the question is, how to manage anticoagulation in patients with hemorrhagic stroke and atrial fibrillation?
Usually, atrial fibrillation gives rise to thrombotic stroke. Hemorrhagic stroke, yesterday when a case came after surgery of blood clot. So he was having bradycardia. Either they have bradycardia or they have ventricular arrhythmias. So we mostly have to use drugs like calderone, membrane stabilizing agents. So we don't have to use blood thinners or these modern anticoagulants. So we have to control the rhythm and rate. Beta blockers, diltiazem, and calderone, amiodarone, these are the drugs which we use. So there is no clash between the aim of therapy, so we can easily manage.
Thank you so much, sir, for answering all the questions. And this was the last question for today's session. I would like to thank all the viewers, and I would like to thank you, sir, for taking out your valuable time and for being here at our platform.
Thank you.
So for today, we can conclude here, sir. Thank you, sir.